Professor Ayman Abid is going to speak about the dysplastic hip femoral side difficulties. Tfadl, Dr. Ayman.
Dr. Ahmed, thank you very much. It's a real pleasure to be with you this evening. As being covered by my friend and colleague, Dr. Ibrahim Al-Ganzouri, given us a very good resume of what's happening on the acetabular side and how to manage the acetabular defects. Obviously, the problem is not only on the acetabular side, but there are quite a lot of difficulties that can be faced on the femoral side. And therefore, in the coming 10 minutes or so, I'm going to cover the common femoral deformities that we see in dysplastic hips, the sequence of soft tissue releases and the limitations that we find, and the debates around how much soft tissue release and how much we gain from soft tissue release. We'll then look at the aims of the reconstruction itself and how to restore the biomechanics, and possibility of using osteotomies, the types of osteotomies and techniques. We'll perhaps touch on the approaches. We'll talk a bit about the subtrochanteric osteotomy as an option. And finally, I'll finish with the distal femoral osteotomy, the advantages and disadvantages. The challenge on the for the dysplastic hip that we see is that there is proximal migration of the head of the femur. And one of the aims, as we know, is to bring the center of rotation down into the true floor of the acetabulum. So we have to overcome the problem of the proximal migration and the leg length discrepancy. We know that there are rotational deformities in the proximal part of the femur in cases of dysplasia, and it has been noted previously that there is increased femoral neck anteversion in types 2 and 3 in particular. There is a valgus angle for the neck in the majority of cases, and in many occasions, there is a posterior placement of the greater trochanter, which would hinder the abductor mechanism function and reduce the lever arm for the abductor muscles. We know in many occasions that we, in addition to the deformities, the rotational deformities, that there is a narrow medullary canal. Many of these patients are presenting in arm gauge, and they have very strong cortex and narrow medullary canal as part of the problem that we have to think of preoperatively and plan on how to overcome it. As been presented and shown, many of the cases of developmental dysplasia or congenital dislocation of the hip have the problem of a valgus knee and become aggravated when you have corrected the hip deformity. And we have to keep in mind that many of these cases might have received the previous surgical intervention to correct the problem of the dysplasia in form of proximal femoral osteotomies. And therefore, you may be faced with the presence of metal work that is left behind on the proximal femur. You have to think of how to remove them because it might represent a very difficult issue to solve intraoperatively. The aim from the reconstruction that we perform in cases of hip dysplasia is to try to restore the biomechanics, the abductor function. And if you look at the preoperative X-ray and the plan for it, you find yourself that, as I said, you need to correct the presence of a leg length discrepancy, but you need also to restore the offset of the abductor mechanism and to avoid complications. And we know that if we stretch too much while trying to bring the center of rotation down, bring the femur down to correct this leg length discrepancy, we are faced by the problem that there are limits for the soft tissue release, and there are limits for the tension that we can place on the femoral as well as the sciatic nerves. Therefore, it is very important to think of the correction. And before the preoperative X-ray that you see on the left-hand side and the post-operative X-ray with bringing the hip offset to be similar to the other side, center of rotation of the hip down to the true floor of the acetabulum. Between this And that X-ray, the post-operative X-ray, I mean, there is quite a lot of technical steps that we consider in terms of correcting the soft tissue balance, as well as restoring the offset of the femoral neck and restoring the lever arm to the abductor mechanism of the hip joint. There is always a debate, and I'm raising questions more than answering these questions. Actually, when I look at the overlap between the true and the apparent leg length discrepancy, we see patients when we measure the actual true leg length discrepancy, we find it 3-4 centimeters. But when we look at the apparent leg length discrepancy, we find it much more higher. And this is obviously related to the obliquity being placed on the pelvis as a whole and the soft tissue tightness. And there is no clear measure of how to assess the degree of soft tissue tightness preoperatively. All we can do preoperatively is to look at the leg length discrepancy. But we don't know whether how much tightness and the magnitude of the distal displacement that we can perform by performing just soft tissue release. How much we can limit the acute correction as well, because it is always said, and it is a quote from one of the publications, that you can only stretch to 4 centimeters or 5 centimeters. But this is obviously a very rough measure, because the size of the patient itself is different from one to another, and the pathway of the sciatic nerve is different from one to another. So we wouldn't be able preoperatively to tell for sure that we would be able to bring this greater trochanter down to the level that we wish to achieve by just the soft tissue release. We don't know how much soft tissue is going to give us. And as I said in the previous slide, when you look at the preoperative X-ray, the actual true leg length discrepancy is a small amount, perhaps 3 or 4 centimeters. But intraoperatively, this is not giving you enough indication or an absolute indication that you may not need to perform a shortening osteotomy to achieve balance for the soft tissue postoperatively and to restore the hip offset. There are different strategies, obviously, to correct the proximal migration of the femur. And one of the strategies is to perform preoperative destruction. Another strategy is to perform the transtrochanteric approach. And the transtrochanteric approach would allow you to have the abductor mechanism detached from the femur, gives you an excellent approach to the femoral and the acetabular side. And if a femoral shortening is going to be performed, it can be performed at the level of the lesser trochanter or the trochanteric area, rather than going into a subtrochanteric area. Obviously, this is sometimes faced with the fact that trochanteric non-union might happen as a result of detachment of the greater trochanter. And we know that the trochanteric or transtrochanteric approach has been popularized by Chalmers in the early 70s, but it's being used by some surgeons in cases of DDH nowadays. There is obviously the strategy of performing the distal femoral osteotomy. As I said, soft tissue release. How much soft tissue release is enough, or how much is adequate to bring the center of rotation down and bring the femur down? Perhaps it is essential in these cases to perform a circumferential capsulotomy. This is the first step. Gluteus maximus deep insertion can be released, which is another important step. Many of these cases need to have the abductor tenotomy, whether it's usually performed as a percutaneous tenotomy. In the majority of cases, the psoas release is performed in many occasions, and the sliding of the gluteus medius and minimus of the iliac wing is another soft tissue release procedure that would allow bringing the greater trochanter down to the level that you would wish to achieve. This soft tissue release, as I said, and the lengthening being achieved may not be adequate to create a balanced hip with a good soft tissue balance, because in many occasions you are faced with the fact that having performed these releases, you still have a very tight hip, or you cannot even reduce the hip back into position when the center of rotation of the acetabulum is restored to the anatomic center of rotation. And that's why the role of osteotomy came into place. And the subtrochanteric osteotomy has been proposed by many authors. There is a wide experience around the literature with the subtrochanteric osteotomy, 10 centimeters from the greater trochanter, and performing the osteotomy and the shortening that is needed to relax the soft tissue and allow reduction of the hip and the balancing of the soft tissue with offloading this soft tissue tightness by taking part of the metaphyseal, diaphyseal junction out. It can be around a centimeter or more, depending on how high is the dislocation preoperatively. I'm going to go into some details of the subtrochanteric osteotomy through a case scenario I'm presenting in this case, and you see that what appears to us with the preoperative leg length measurement, that this lady had around 7-8 centimeters of shortening. When you measure this on the X-ray, you may not find an 8 centimeter of shortening, but at least what we see as a combination between true and upfront shortening in this left leg is around 8 centimeters or so. And in this case, perhaps it's better to be prepared with performing a subtrochanteric osteotomy. The steps is to establish the center of rotation of the hip first. So restore the center of rotation of the hip by performing the acetabulum first. Start reaming the femoral canal and make sure that you can ream it adequately, because in many occasions we have a very narrow medullary canal that needs manual reaming and perhaps power reaming of the diaphyses before you can insert your broaches into the proximal femur. Broach the proximal femur and see how much you need to bring your femur down when the broach is in, and perhaps to start first by performing the subtrochanteric osteotomy while the broach is in. And once you have completed your osteotomy, insert the broach in first, make a trial reduction of the hip of the proximal part while the broach is connected to the proximal part of the femur, and see the overlap that is being created between the shaft and the proximal part of the femur to see or judge how much of the bone you need to take out to balance your soft tissue. We usually err towards having a smaller part removed at the beginning, and obviously you can increase this removed part as the soft tissue balancing needs to be balanced with removing parts more of the femur. The fixation of the osteotomy starts while the broach is already holding proximal to distal fragments, inserting the plate outside with unicortical screws, at least the provisional fixation, and then you remove the broach and insert the actual stem and complete the fixation of the site of the osteotomy. So it is a provisional fixation while the broach is in, and then you remove the broach out and insert the definitive stem into the proximal and distal parts of the femur and complete the fixation. If you need to add circular wires or bands around the proximal femur or the distal femur to improve your fixation, you can do so. In many occasions, some surgeons prefer to have a straight stem into the, in these cases of dysplasia, because when you have a straight stem, you can alter the rotation of the greater trochanter. You can bring it a little bit forward, and the straight stem wouldn't jeopardize your rotation or wouldn't affect rotating the distal or proximal parts of the femur to achieve the combined anteversion that would give you the stability that you would wish to have into your implants. This is not a case of DDH, it's a neglected varus, congenital coxavara. But again, this is a proximal migration that is quite similar to Crow type 4. And you see that there are deformities into the proximal femur, narrowing of the medullary canal, and to define the true medullary canal and to ream this medullary canal to achieve good fixation of a cemental system is something that you have to plan preoperatively. And as I said, you have to be prepared with performing the subtrochanteric osteotomy to achieve the soft tissue balance that you wish to have and restore the having restored the center of rotation of the hip and giving the abductor mechanism the necessary lever arm to restore the function and allow the hip to be balanced as well. So this is post-operatively, and you see that how much migration had happened to the greater trochanter from being attached to the iliac wing down, but this wouldn't have been achieved without performing the subtrochanteric osteotomy. One of the techniques of the subtrochanteric osteotomy is to slice the fragment that you have removed and use it as being used on the right side here as a graft around the osteotomy site. There is a technique of the Chevron osteotomy, which is a very good technique that provides the stability of the osteotomy site, having inserted a straight cemental stem into the femur. The difficulty with the Chevron stem is that it doesn't allow you to adjust rotation once you have performed the osteotomy to allow for the ends of the bone to meet each other. There is finally the technique of the distal femoral osteotomy, and perhaps it is a good idea to go away from the stem bend by performing an osteotomy distally in the supracondylar area. It allows you to correct a valgus deformity, as been shown in Professor Ganzouri's presentation. So you can perform a correction of the valgus deformity in addition to performing a hip arthroplasty and fixing the osteotomy distally away from the stem. But again, it is an extensive approach, because you're going to approach the whole of the shaft of the femur, almost the whole of it, or another incision, an extensive incision distal in addition to the proximal incision. There is a possibility, if you ignore the fact that you have to keep at least a 2 centimeter between the stem and the last screw of your plate to create a stretch riser between the end of the stem and the plate for the osteotomy, and this obviously should be avoided. But again, it's very useful technique when there is an associated valgus deformity of the knee that needs to be corrected at the same time of reconstructing the hip joint. I will stop here and send a take-home message to my colleagues listening to this talk, that there are priorities and aims for the reconstruction that can be kept in your mind while you are planning for performing a hip arthroplasty for a dysplastic case. Correcting the biomechanics of the hip and having a good offset and lever arm for the abductor mechanism is something that you have to aim for and plan for preoperatively, and you have to think of avoiding complications. There is no clear cut of when to perform a subtrochanteric osteotomy and when not. And in the majority of cases, you would be just discovering this intraoperatively, and therefore you need to be prepared for performing the subtrochanteric osteotomy if soft tissue release is not adequate. You perform the soft tissue release sequentially, and you consider the structures that we mentioned from the adductors as well as flexors and the circumferential capsulotomy that would allow you to bring the proximal femur down. If subtrochanteric osteotomy is performed, make sure that you correct the rotational deformity and have a good fixation of your stem as well as for the osteotomy that was created. And thank you very much for your attention.